Today's presentation explores who benefits from the healthcare industry and how its structure impacts access, quality, and outcomes. We'll examine how fragmentation, structural drivers, social determinants, public health, and unpaid caregiving collectively shape health inequities and life expectancy. Looking at the first theme is the fragmentation and structural drivers. Care fragmentation occurs when patients move through disconnected healthcare systems, leading to inefficiency and worse outcomes. Superutilizers, often young minority or Medicaid patients, frequently visit multiple facilities with little follow-up or information sharing, exposing systemic and organizational failures. Founded by Kelton Bourne et al. 2021. Mental health services reflect how institutional hierarchies and rigid procedures often prioritize rules over patient needs, reinforcing fragmented care. Inpatient treatment commonly suffers from inconsistent plans, limited engagement, and poor communication, with the divide between patients and providers undermining trust and recovery, making fragmentation both a systemic and human issue. Founded by Cockerham, ND. Now, similar issues arise in acute care settings, where emergency rooms exhibit boarding delays that reflect misaligned institutional priorities and strained resources that compromise timely treatment and deepen health disparities. Quote founded by Pantagania and Jetlina, 2024. Therefore, through these patterns, it should show that structural flaws drive fragmentation and reinforce inequity in healthcare. Now, Beck 2017, page 4, traces the origins of fragmentation to a historical and institutional split between fields of medicine and dentistry in the 1840s. This division created distinct systems of training, insurance, and service delivery, setting the stage for today's siloed healthcare structure. It should be acknowledged that while these two realms of health are structured to be distinct from one another, they do intersect and therefore influence consequences such as the preventable death of 12-year-old DeMonte Driver, who, due to an untreated tooth infection, reflected how the differences in insurance coverages make dental care less affordable and inaccessible than medical care, negatively impacting health outcomes. This case highlights how policy and institutional decisions perpetrate inequities. Moreover, it is prevalent to take into account that the existence of systemic inefficiencies stem from the medical industrial complex, MIC, which includes hospitals, pharmacies, insurers, researchers, institutions, prisons, and nonprofits. Driven by profit, the MIC shapes who gets care, which treatment matter, and whose bodies are valued. The MIC consists of four pillars: eugenics, which controls bodies; charity and ableism, which treat access as benevolence; desirability sets the foundation of normal bodies; and population control, which drives reproduction and incarceration policies. Through the examination of the MIC, we can see how the embedded structural inequalities interplay within the healthcare industry, as taking consideration that historically, the MIC was utilized to harm marginalized groups through measures such as sterilization and experimentation, and how it is continued practice today, which showcase how consolidation deepens fragmentation by prioritizing profit over care. This quote was found by the Reichritz 2018, Burns and Polly 2018, and Summers 2021. However, while this structure reinforces inequality, some providers advocate for community-based care that resists profit-driven norms. Now we're going to be talking about the global impact of fragmentation. Now, healthcare fragmentation is a global problem, driven by profit motives, regional disparities, and weak coordination beyond the U.S. Kahneman et al. 2014 described China's overcrowded hospitals, India's unregulated costs, South Africa's two-tiered system, Brazil's public-private divide, and Egypt's staffing shortages. Even high-income nations like Italy, Germany, and the U.S., where more than 13% of Americans still have no health insurance, experience fragmented care. These inequities are reinforced by social and institutional mechanisms, particularly in multi-payer, market-driven systems that prioritize profit over prevention, thereby compromising access, quality, and health outcomes worldwide. This quote was found by Med School Insiders 2022, Crash Course 2018. Now, why does this matter? Fragmentation and structural drivers reveal how systemic inefficiencies, institutional hierarchies, historical decisions, and profit motives determine who benefits from healthcare and who remains vulnerable. Addressing these inequities requires patient-centered policies, systemic reform, and a focus on equity over profit. Next theme we're going to be focusing on is social determinants. With the structural inequality in healthcare, health is often viewed as a biological or behavioral model, but a sociological lens shows that it is deeply shaped by social, economic, and political forces. Quote founded by Freud and McGeer, ND, page 4. Who highlights how institutions like families, workplaces, and healthcare systems influence both health risk and access to care, challenging medical models that focus solely on individual pathology while overlooking these broader structural factors. This is especially clear in mental health, where social determinants such as systemic oppression, chronic stress, and trauma are often treated as individual issues rather than outcomes of social injustice. This quote was found by Ashhan 2022. These realities underscore the necessity of a structural health model, as interventions that ignore social causes risk failing to address the root of the problem. For example, insurance mandates such as for autism care in Massachusetts require applied behavior analysis, ABA. While widely accepted, ABA's standardized model fails to address tailored patient needs. This ultimately depicts how the rise of private equity in healthcare reveals how profit motives erode patient-centered care. Summers 2021, page 6. Now, a structural perspective is also essential for understanding the disparities in access, affordability, and health outcomes within the American healthcare system. as Lipshort's and Beer's 2025 page 2 analyzed the proposed One Big Beautiful Bill, which would cut Medicaid and Medicare, tighten eligibility, and add work requirements, potentially leaving up to 10 million Americans without coverage, including those with chronic or life-threatening conditions. This human cost is illustrated by Matthew, a Crohn's disease patient in Massachusetts, who depends on Medicaid for life-saving treatment. Found by Vox 2017, 916 through 1019, depicts that, however, since Medicaid programs vary widely by state in eligibility, scope, and coverage, his access is dependent on more geographic basis than medical need, which underscores how policy decisions, rather than biology or personal effort, largely govern health outcomes in the U.S. Now, such disparities arise from treating healthcare as a commodity, as market-driven, profit-focused reforms create fragmented care marked by multiple bills, poor coordination, and complex administration. This quote, found by Sack-Leroy and Roteru, 2017, page 25 through 26, emphasize that these reforms disproportionately harm the most vulnerable, people with disabilities, older adults, and those with chronic illnesses, who have higher healthcare needs but face greater barriers. By shifting the focus from collective support to individual responsibility, neoliberal policies place the greatest burden on those least able to bear it. Furthermore, even reforms intended to alleviate these problems, such as the Affordability Care Act, ACA, cannot fully resolve them, as while the ACA and Medicaid expansion have improved coverage, they have not eliminated racial and ethnic disparities in access, as Summers et al. 2025, page 1 indicates that Black, Hispanic, and Indigenous populations remain significantly more likely to be uninsured compared to white Americans. This shows national reforms can provide relief, but not dismantle deeper structural inequities rooted in racism, poverty, and exclusion that continue to shape the U.S. healthcare system. To effectively reduce healthcare inequities, professionals must understand the wide range of factors influencing health. Russell et al. 2017, page 4, found that students in medicine, nursing, and pharmacy recognize diverse determinants, including diet, politics, and spirituality, highlighting the need for interprofessional collaboration. This approach, grounded in distributed knowledge, where each profession contributes unique insights, is essential for delivering care that is both clinically effective and socially responsive in diverse societies marked by structural inequalities. The next slide we're going to be talking about is the U.S. healthcare system exceptionalism. Now, to grasp why the U.S. healthcare system continues to generate such inequities, we need to examine its underlying ideological foundations. This quote, found by Thyroid 2017, page 3 to 4, links that the U.S. healthcare failures to American exceptionalism. The belief is found following its own path, often opposing global norms. As unlike other wealthy countries with universal systems, the U.S. relies on a fragmented model of private insurance and market competition, resulting in higher costs and inequality. As previously mentioned, in the relation to the MIC, these issues stem from historical injustices, like the exclusion of Black workers from safety nets and delayed hospital desegregation, which continue to affect access to care today, despite the significant investments and efforts aimed at resolving them. According to Centers of Medicare and Medicaid Services, 2025, page 1, the U.S. spent $4.9 trillion on healthcare, about 17.6% of the nation's GDP. Yet outcomes remain profoundly unequal, and this enormous spending has not led to improved public health. As Crash Course 2016, 420 to 435 emphasizes, Americans spend nearly twice as much per person on healthcare compared to citizens in other developed nations, yet still experience lower life expectancy, higher infant mortality, and worse chronic disease outcomes. This paradox underscores the inefficiency of profit-oriented healthcare system that prioritizes financial gain over equity, leading to excessive costs, fragmented services, persistent health disparities, and diminished public health outcomes. Furthermore, despite rising healthcare costs, improvements in health outcomes remain minimal, reflecting a societal reluctance to prioritize prevention over profit and a failure to pursue systemic reform over more concern for maintaining their agenda of profit. Now, why does this matter? Health is not just individual or biological. It is socially produced. Structural factors like class, race, policy, and institutional power shape who gets sick and who gets care. A sociological perspective reveals that health disparities are outcomes of inequality and not personal failure. Addressing them requires systemic change, not just medical solutions. Next, we'll be looking at the theme of public health prevention and the role of unpaid caregivers. We'll be looking at structural drivers of public health and prevention first. As public health and prevention are inherently sociological, they reflect how societies structure care, distribute resources, and value specific forms of care. Preventive strategies like vaccination, health education, sanitation, screening are essential, but their success depends on access, trust, cultural fit, and navigations of complex systems. As Crash Course 2022 emphasizes, prevention addresses health issues before they become severe, reducing reliance on costly medical treatments and shifting the focus from cure to care. However, this shift requires systemic change and more inclusive healthcare practices. As Boone et al. 27, page 6 note that traditional trials often miss critical connections. A systems approach that considers institutional, social, and behavioral factors is more effective in impacting health than clinical interventions. Addressing social determinants requires structural solutions like the universal health coverage, which ensures equitable access regardless of SES. Nations with universal systems like the UK, Canada, Germany, Brazil perform better in prevention and chronic care. In contrast, the fragmented US system, which mixes employer-based insurance, Medicare, Medicaid, private plans, and limited public options, often leaves millions underinsured or uninsured. As Kaiman et al. 2014 note, countries with broadly accessible care achieve better preventive outcomes, manage chronic conditions more effectively, and reduce disparities. Conversely, underfunded systems in countries like India, Egypt, and US fail to provide consistent prevention, leading to greater reliance on emergency care and higher long-term costs. Now, the US healthcare system is also shaped by what Crash Course 2018 terms as the 5 A's, which consist of access, availability, accessibility, accommodation, acceptability, and affordability. And these dimensions highlight how care is differently available depending on geography, culture, economic status, and institutional design. For example, rural areas may lack specialists, while urban centers face long waits, and these cultural gaps between providers and patients can cause mistrust or misdiagnosis, especially among immigrants and racial minorities. And above all, affordability remains a critical barrier. High premiums, copays, deductibles, and unexpected bills discourage preventable care in a fee-for-service model that prioritizes volume over value. Next, we'll be talking about the unpaid caregiving and inequality. Beyond these systemic access issues, another crucial yet often invisible factor shapes healthcare outcomes: unpaid caregivers. Typically, they are family members, and they provide crucial support that maintains the health and independence of their loved ones, bridging gaps in formal care and often preventing institutionalization. In 2021, 53 million Americans provided an estimate $600 billion in unpaid care. This quote was found by Simbo 2025, Horowitz 2025. Though structurally embedded in healthcare, this labor remains undervalued because it exists outside market systems and is shaped by gendered expectations of kinship and obligation, as caregiving reflects gender inequality, with women making up about 61% of unpaid caregivers, with many individuals part of the sandwich generation that resorts to caring for both children and their aging parents. And this dual burden further affects their employment, health, and long-term financial security. This quote was found by Simbo 2025, page 2. Therefore, the lack of visibility and lack of compensation for caregiving depicts how society's foundation is influenced by patriarchal norms, which frame care as a private responsibility rather than a public good, thereby excluding it from labor protections such as paid leave and financial support. Furthermore, the over-reliance on unpaid labor highlights the impact of neoliberal health policy, which shifts care responsibilities from the state to individuals and families. As public health care is cut or privatized, families must provide care using their own time, money, and energy, a model that deepens class and racial inequalities, particularly for low-income households and minorities. These also exacerbate racial disparities, as minorities are more likely to provide informal care due to mistrust of institutions, limited access, and cultural expectations around elder care. Now, why does this matter? Prevention and public health are key to saving lives, reducing costs, and promoting equity by addressing social determinants like policy, infrastructure, and culture. Effective healthcare systems integrate prevention and support for unpaid caregivers to enhance outcomes and sustain essential labor. Only by addressing these structural realities can prevention fulfill its promise of improving health for all, and not just for those who can afford it. Next, we'll be looking at the sociological conclusion of my entire presentation. Through this presentation, I hope you gained insight into how the structure of the healthcare industry is predominantly shaped by the intersection of social, economic, and political forces, not just medicine, as fragmentation, profit motives, and historical inequities determine who accesses care and who benefits. Social determinants and institutional structures create unequal outcomes, while prevention, public health, and unpaid caregivers reveal that care extends beyond formal institutions, highlighting society's reliance on both structural systems and invisible labor. Therefore, to effectively address these disparities, it requires policies prioritizing equity, coordination, and collective well-being, recognizing health as a social outcome, not just an individual responsibility. And lastly, I have all the references that I have utilized within the presentation, and I hope you guys enjoyed. Thank you.